Welcome back to Wally's nursing videos. Today we're covering an important topic for any nursing student or practicing nurse: elimination disorders, hepatic disorders, and critical care conditions like sepsis and ARDS. We'll break down the essential pathophysiology, nursing interventions, diagnostics, and therapeutic approaches, focusing on ulcerative colitis, UC, Crohn's disease, liver issues like cirrhosis, and serious complications like sepsis and acute respiratory distress syndrome, ARDS. Let's dive in! Elimination disorders, ulcerative colitis, and Crohn's disease. Let's start by looking at these two inflammatory bowel diseases and how they impact our patients. Ulcerative colitis, UC, affects only the colon's mucosal layer, causing continuous ulcerations that often lead to abdominal pain, bloody diarrhea, and an increased cancer risk. Crohn's disease is different. It affects any part of the GI tract, from the mouth to the anus, and impacts all bowel layers. It's known for causing skip lesions, fistulas, and strictures, leading to malabsorption and severe nutrient deficiencies. Pathophysiology connections: both UC and Crohn's involve chronic inflammation, leading to diarrhea, abdominal pain, and fatigue. Malnutrition is a huge issue here. Crohn's, especially when it affects the small bowel, interferes with nutrient absorption. UC patients may also struggle with nutrient intake and hydration. Bowel obstructions and fistulas are especially common in Crohn's due to the extensive damage, but UC patients may also face issues like toxic megacolon, a potentially deadly colon dilation. Nursing care for UC and Crohn's. Our primary nursing goals are to maintain hydration, electrolyte balance, and nutritional support. Obstruction care: watch for severe pain, vomiting, and dehydration. We may need to place an NG tube to relieve bowel rest and administer IV fluids. Peritonitis risk: if perforation occurs, be prepared for interventions to prevent sepsis. Fistula management: protect the skin around stomas with barrier products and teach patients effective stoma care. For malnutrition, monitor weight, check serum albumin and prealbumin levels, and administer TPN if needed. Diagnostics: use CBC for anemia and infection signs, SED rate for inflammation, and serum albumin to check nutritional status. Medications and interventions: infliximab and sulfasalazine reduce inflammation, critical for preventing disease progression. Parenteral nutrition, TPN, is key for cases with severe malnutrition and when bowel rest is required. Hepatic disorders. Next, let's talk about hepatic disorders, particularly alcohol-related liver issues like cirrhosis. Alcohol's effect on the liver. Over time, alcohol damages liver cells, leading to fatty changes, fibrosis, and cirrhosis. Portal hypertension. Scarring blocks blood flow through the liver, increasing pressure in the portal vein. This leads to ascites, esophageal varices, and splenomegaly. Other complications include hepatic encephalopathy, hypovolemic shock from ruptured varices, and metabolic derangements affecting vitamin storage and hormonal balance. Nursing care. Our main goals here are to manage symptoms, support liver function, and encourage lifestyle changes. Diet. Low-protein diets can reduce encephalopathy symptoms. Low-sodium diets help control ascites. Safety. Patients with encephalopathy are at high risk for falls and bleeding. Alcohol screening. Use validated tools to assess alcohol use and refer patients to support programs. Medications and procedures: lactulose for lowering ammonia in hepatic encephalopathy, octreotide to reduce variceal bleeding, rifaximin to eliminate ammonia-producing bacteria in the gut. Procedures like TIPS, a shunt to alleviate portal hypertension, and paracentesis to drain ascites fluid. Diagnostics look at ammonia levels, liver function tests, LFTs, coags, CBC, and BMP to assess overall liver function and stability. 3. Immunodeficiency conditions, sepsis, and ARDS. Lastly, let's dive into the immunodeficiency conditions of pneumonia, sepsis, septic shock, and ARDS. Pneumonia often starts with alveolar inflammation and impairs gas exchange. Sepsis is a systemic inflammatory response to infection, potentially leading to organ dysfunction. Septic shock and MODS, multisystem organ dysfunction, arise from severe infection, causing poor blood flow and organ failure. ARDS. Direct or indirect lung injury increases lung permeability, leading to life-threatening hypoxemia. Pathophysiology connections. Sepsis can progress to septic shock, MODS, and even ARDS due to excessive inflammation and multiple organ failures. Nursing Care Sepsis Bundle, 1-Hour Bundle. The Sepsis 1-Hour Bundle is a set of urgent interventions that must be initiated within the first hour of sepsis recognition. The goal is to stabilize the patient quickly and reduce the risk of progression to septic shock and organ failure. Here's what each component involves. Administer IV fluids. Start with a crystalloid solution, like normal saline, at 30 ml/key, as rapid fluid replacement helps to maintain blood pressure and perfusion. Measure lactate levels. Lactate indicates tissue oxygenation and is used to assess the severity of sepsis. Elevated lactate can signal poor tissue perfusion. If the initial level is high, repeat it within 2 to 4 hours to monitor progression. Obtain blood cultures before antibiotics. Cultures help identify the infection source. 2 sets from different sites reduce the chance of contamination, providing a clearer picture of the infection. Administer broad-spectrum antibiotics. Time is critical in sepsis, so antibiotics should be administered within an hour after identifying sepsis, even if cultures aren't back yet. These help target the underlying infection. Administer vasopressors, if needed. If the patient's blood pressure is still low after fluids, vasopressors, like norepinephrine, can help to maintain mean arterial pressure, MAP, above 65 mmHg. This ensures adequate blood flow to organs. SOFA and QSOFA scores. The Sequential Organ Failure Assessment, SOFA, and Quick SOFA, QSOFA scores help assess organ function and identify the severity of sepsis. SOFA score, a comprehensive scoring system that evaluates 6 organ systems: respiratory, cardiovascular, liver, coagulation, renal, and neurological. Each organ system is scored from 0 to 4 based on function. A change of 2 or more points from baseline suggests a significant decline, which could indicate sepsis. QSOFA score, a simplified version used outside the ICU. QSOFA looks at 3 criteria: altered mental status, systolic BP, or 100 mmHg, and respiratory rate, ETRO 22 min. Patients meeting 2 or more of these criteria are at a higher risk for sepsis. ARDS management for acute respiratory distress syndrome, ARDS, respiratory support is key. This often includes ventilator support. ARDS patients are often placed on a ventilator to maintain oxygenation, using low tidal volume to protect lung tissue from further damage. Prone positioning. Placing the patient on their stomach helps to improve lung expansion and oxygenation as it redistributes ventilation more evenly. Sedation. Patients on mechanical ventilation are usually sedated to reduce stress and agitation, promoting better ventilatory compliance. ECMO, extracorporeal membrane oxygenation. In severe ARDS cases where oxygenation is critically low, ECMO can temporarily take over the function of the lungs. Blood is oxygenated outside the body, bypassing the lungs and allowing them to rest and heal. Diagnostics ABGs, arterial blood gases, ABGs, are essential in evaluating oxygenation, carbon dioxide levels, and blood pH. In patients with ARDS or sepsis, ABGs help monitor the severity of respiratory distress and guide ventilation settings. Nurses frequently draw ABG samples to assess gas exchange efficiency and monitor for hypoxemia, hypercapnia, or acid-base imbalances. PF ratio, PaO2-FiO2 ratio. The PF ratio helps assess ARDS severity. It's calculated by dividing the arterial oxygen level, PaO2, by the fraction of inspired oxygen, FiO2, the patient is receiving. Normal, greater than 300, mild ARDS, 200 pound 300, moderate ARDS 100, 200, severe ARDS less than 100. A decreasing PF ratio indicates worsening oxygenation and may prompt changes in ventilatory support. Medications and interventions, ventilator and sedation support. In ARDS management, mechanical ventilation is crucial to support breathing. Low tidal volumes and high positive end expiratory pressure, PEEP, are often used to prevent further lung injury. Sedation helps keep patients calm, minimizing resistance to ventilation and improving oxygenation. Proning and ECMO for severe ARDS cases. Proning redistributes lung pressures, improves alveolar ventilation, and enhances oxygenation. This technique is often applied for 12 to 16 hours at a time in severe ARDS. ECMO. When other interventions aren't sufficient, ECMO temporarily supports gas exchange outside the body, giving the lungs time to recover. IV fluids and pressors in septic shock. When fluid resuscitation alone doesn't stabilize blood pressure in septic shock, vasopressors are essential. Norepinephrine is commonly used to improve blood pressure by tightening blood vessels, ensuring organs receive enough oxygenated blood. Antibiotics and sepsis antibiotics are a cornerstone of sepsis management, as timely infection control is critical. Ideally, they're administered within the first hour of sepsis recognition. Broad-spectrum antibiotics are used initially to cover a wide range of pathogens until specific cultures identify the exact infection. Wrapping up these complex disorders, UC, Crohn's disease, liver disease, and critical conditions like sepsis and ARDS, all require us to think critically about patient care, diagnostics, and appropriate interventions. By mastering these, we can provide effective, evidence-based care and improve patient outcomes. If you found this video helpful, don't forget to like, subscribe, and share with your fellow nursing students and colleagues. Thanks for tuning in to Wally's nursing videos, and see you next time for more insights into nursing care.